time to go in cath lab and for the intra-procedural imaging for LAAC. It's a great pleasure to share this session with Nina and with Laura, Jens Erik, and Ignacio, that are our experts. Nina, can you start with the session?
So we had a really deep discussion on what is really needed as imaging information. So Sergio, you could start maybe to come a little bit back to the roots. So what is really essential? So what do we really need to know from imaging? So which information is essential?
Okay, we have done a very precise pre-procedural planning. We know the anatomy of the patient. We have a clear idea of each single step of the procedure, and we have decided the device. Now it's time to go in cath lab, and what we want to do is to do a precise device placement, minimize the complication, and ensuring procedural success for our patient. The procedure is, in general, based on a multi-imaging modality. In the general practice, the fluoroscopy is the base, supplemented with the echo in different kind of modality, TE, mini TE, or ICE. In my personal view, is exactly the opposite. It's an echo based and supplemented by the fluoro. But the point is what we ask to the imaging for a perfect procedure. Basically, we need to exclude the presence of thrombo or pericardial effusion, to check again the anatomy of the LAA, of the main heart structures that we are planning during the procedural planning, to guide a precise transseptal puncture, to guide the procedure with the perfect placement of the device, and at the end of the procedure have a clear idea if we had some complication. The first step is the exclusion at the beginning of the procedure. We need to exclude the thrombo and pericardial effusion and to check again, a double check of the anatomy of the LAA. This is extremely important to assess the presence or not of pericardial effusion. At the end of the procedure, if you have 2 millimeters of pericardial effusion, oh my God, it was present at the beginning of the procedure or it occurred during the procedure, to confirm again the presence of the thrombus and a double check of the anatomy of the LAA, including the orientation, the ostium, the landing zone, etc., just to confirm that I did a good planning. Transseptal puncture, we discussed yesterday intensively regarding this very critical step of the procedure, and we know that we have in general to do the transseptal puncture in the inferior posterior part of the fossa vallis, but we have to personalize on the base of the LA orientation, and it's essential to have both information in craniocaudal and anterior posterior direction of the fossa vallis, because it's not only necessary to do the puncture inside the fossa, but in a precise point of the fossa. And the guidance of the device deployment is essential. We have to make all the efforts to be coaxial with the main axis of the LA. It's important to get the best alignment. The correct dip, we have discussed before how it's important to place the device in a correct position at the level of the ostium, to check the device compression, the stability, because we want to avoid the complication. We discussed yesterday how it's important to avoid complication, because it's rare, but is the source of, is probably the worst complication, and to check the final deployment. And finally, to monitor the procedural complication, at the end of the procedure, we had to reevaluate the situation. We want to exclude the presence of pericardial effusion if the device is correctly placed, or exclude eventually embolization, to check for the stroke and embolization or other kind of form of embolism, and to check carefully the presence of peri-device leak. And this is the end of the procedure. Now we go in the session, and we will discuss step by step all the single aspects of the role of the imaging for a successful procedure. Thank you.
Thank you so much, Sergio. So maybe just to get an overview, is somebody just using fluoroscopy during the procedure? If you could raise your hand. Just fluoroscopy. Okay, fluoroscopy in addition to some, as fluoroscopy is supported. So there's nobody who's just using fluoroscopy. So who's using TE in addition? Who's using ICE in addition? Oh, just, yeah, a couple. Okay, interesting. And who's using the mini probes? Occasionally? Okay, so it seems that everybody has something to support fluoroscopy to make a decision.
But Nina, the question is, do we think that the fluoro is the first line for the imaging, or do we think that echo is the first line? In my personal opinion, is the main source of information is from the echo. The fluoro is a supplementary information.
So which supplementary information do you get from fluoro? What is important for you?
Yes, because you have the position of the guiding catheter. You have to see the position of the device during the opening phase, but the really impact of the device and the position of the device and the interaction with the device and the anatomical structure, the main information came from the echo. In different solution, we can ICE or TEE or what else.
Is somebody doing the procedure completely TEE guided? Sometimes? Okay. Yeah, so I mean, let's go into the subject. And Laura, you have a lot of experience with the mini TEE, so and you can give us some advice how we could use it during the procedures. And you can point out maybe a little bit, so what are the difference if you compare it to a normal TE probe?
So thank you for the introduction, and I really like this topic for my talk because we use it now for almost 2 years, the mini probe. And can I have my slides? And I think the most important part is not the mini itself. For me, the most important part is the 3D guiding, because we talk a lot about planning and specific programs just to make an approach for the appendages, but then how we are going to close these appendages. And I think it's very important to proper guide this closing. So for me, more than a question, if it's a game changer, it's like an affirmation. It's a game changer, the mini 3D TEE. So first, just presenting you the probe. This is the one from General Electric. Now also Philips have a 3D mini probe that is quite similar and also have the lateral wheel. You see that it's something in the middle between the standard probe and the micro 2D probe. And the important thing is that the part of the tube, that one is remaining on the tongue of the patient, it's more similar to the micro than to the standard probe, so the tolerance is great. And these probes have several advantages. For me, first is this good tolerance we do with the patient awake, practically choking. We also have, for appendage and interatrial septum, a similar quality of imaging than the standard 3D probe. We can do a minimalistic approach with this, the patient awake and same-day discharge. And now we also have the 3D eyes, but I think that the problem with the 3D eyes is the cost, because you need to change for the moment your eyes in every patient. So with this probe, you can use it several times. Also, it allows you to do 3D guiding, that it will be the second part of my talk, that I think it's super important during the left atrial appendage closure. And I think this point I just added, that it's also nice to have an imager in your cath lab, because we can add added value regarding the echo and the anatomy, and it's always nice to be a team in the cath lab. So with these probes, we can do a fast turnover and same-day discharge. So this is our initial experience that was published last year. It was our first 62 patients treated with this mini 3D TEE. As you can see, they were quite old, 77 years. They were also quite big, more than 70 kilograms, and the imaging was good for them. The dose of midazolam and fentanyl was very low, around 1 milligram of fentanyl and 25 micrograms of fentanyl. And you see that the X-ray exposure was 8 minutes, and the door-to-door time was around 47 minutes. We use contrast in less than a quarter of the patient, and almost the 80% of the patients have had same-day discharge, so we were quite happy with these initial results. So why use 3D in your cath lab when you are treating the appendage? First, because you can make a transeptal puncture safer, because you can guide it from the bicaval view and just follow the needle, and you can be very, very precise in the point that you want to make this transeptal puncture and see the crossing of the needle just in biplane. But also for me, this second point is very important because you can make, again, measurements in the table. And this is important because, especially with patients with paroxysmal IF, sometimes they have these hypercontractile appendages, and you can make the transeptal puncture, and if the pressure is very low, you can put fluids and make, again, the measurements. And also, in centers with different devices available and high experience, you can even do the pre-planning in the table. It's still pre-planning if you do at the beginning of the intervention. And the patient, again, it's awake, and at the end, it's more or less the same sedation that we put in the echo lab, so it's not a big deal if then you see a protrudent thrombus or something. So this is an example just to illustrate this kind of difficult cases. This is a patient with paroxysmal IF. You can see this appendage with very high contractility. We just make the measurements at the beginning, and you see here a landing zone. We always do it the bottom left. You see that it's more or less like the 60 degrees view in the standard TOE, and then on the bottom right is like the 135, that also you can make here better the measurements, because where I put the blue line, it's also the same plane in the 135, and I do the measurements in the short axis, so I have the real measurement of these appendages. So you can see here that was 12 by 15 millimeters, so we made the transeptal puncture. That was also a little bit complicated for this patient and was great to have biplane. And we measured the pressure in the atrium, and was 1 millimeters of mercury. So we put half a liter of serum, and we obtained 12 millimeters, so we were happy with that, and we repeat the measurements after that. And you see here that it used to be 15 by 12, and now it's 18 by 17. So we changed our two sizes, the device of implanter that we were supposed to implant in this patient. So I think it's a great illustration of how useful it is to have this kind of 3D imaging during the intervention. So we made all the intervention guided with 3D. Now we start doing with MPR, because we can have a very clear 135 view. I will focus a little bit more on that, and it's quite easy to do it when you train a little bit. And I think this feature of can guide the intervention with multiplanar reconstruction is super useful, because we can look at the catheter position and the lobe position while we are doing the intervention, and we can evaluate faster with the 3D the results. This is another patient. As you can see here, it's a patient with not so high contractility. We made, again, the measurements with the 3D probe. And you can see here that in the first attempt, in the upper left, you see how in the supposed 135, we see that the lobe is not exactly inside the appendage, so we can correct this very nicely in the second attempt, that it's in the upper part right. And just talking with Jordi, with the engineer, is exactly this area, the area that now that it's studying patients with previous closure, that he's starting to see some problems in that area, because to cover the pulmonary ridge in the 60 degrees, it's easy, but to look at the 135, if you do it directly or with eyes, it's very difficult. And also, it's not only this area of the 135. In this case, for example, if you see how we made the measurements, the pulmonary ridge, it's a little bit open, and the mitral valve was a little bit close. So you can see here that we can also see how the catheter is going in the 135, and here was not totally coaxial, so you see that we ended with a pulmonary ridge that was not covered. So we just adjust this catheter, just also using the MPR, and you can see here that how with this small change in the angulation, we obtain a perfect result in this patient. So just to finish and to don't make it so long, I just want to summarize my presentation, just saying that with the Mini 3D probe, we can do this kind of minimalistic approach, same-day discharge, and patients are happy with that. They don't struggle during the intervention because they have a very good tolerance. We can reuse this probe. And you have us in the cath lab that I think it's important. You can do 3D guiding. And regarding 3D guiding, I think it's important that if you are very experienced, you can do the screening on the table, but only if you have different devices and so. You can also redo the measurements after ensure that the pressure in the atrium is okay. And you can do this kind of 3D guiding that again, it's not so difficult to do. Now we are doing in most of the patients. And you can also get a better evaluation because I didn't put it, but sometimes when you have doubts, you can just spin around your lobe just to evaluate if you have any leak or not. That this afternoon we will have a talk on that also. So this is all from my side.
Thank you, Laura. Questions for Laura? Yes, we have one question. Can you give the microphone?
Thank you so much. Very excellent imaging provided. It's really, I think, a good way to go. You mentioned multiple use. What does it exactly mean? How fragile is the probe and what's the cost?
Well, in theory, it's smaller. In our case, we only use for the echo lab, so it's something that it's not for everybody. I have it in my room. So I think it needs to be handled with care because it's smaller, but you can reuse it as a standard probe. It's not like the eyes that you can change it, need to change it. We need more time of use of this probe because it was released 1 year ago in the market. We have it a little bit more because we were testing it, but we need to look at that. But if the probe is around 55,000 or so, and for the eyes is around 5,000, you can make the numbers. So I think it's cost effective.
The image is amazing, and but the question of Nina, in this room where we have the most expert in Europe, only 2 centers are using this technology. Yeah. What is your interpretation? Because it's too complex for the operators. Because what is a possible explanation why we are not using this approach in the main of the centers?
I think that first is new because it's a little 1 year and a half for GE, and Philips was, I think, just this year to have this probe. And also some centers, they don't have imager in the cath lab for appendages, so it's another problem. But I think that in most of the centers that they are doing with TOE, with an imager in the cath lab, they can switch to this. Also because we start first with the micro, but now I will not do it with 2D anymore because we didn't have anesthesiologists enough for all the days in the cath lab. And we are not allowed to use propofol or so in Spain without anesthesiologists. But at the end, for the patients, ends to be better because patient is totally awake. When I take out the probe, they are joking and I showing them the images. So I think that the problem is new and they just need to start doing. But it's not so difficult to manipulate if you are doing TOE in your daily basis.
Maybe one comment just according to that, and Marek, then we come to you. I think, well, you have to spend at least 55,000 euro, and I mean, this is a cost factor. This has to be taken into consideration. Yeah. And I think the other point is it's a very nice tool, and I think it works very well for LAA closure, ASD closure, PFO closure. But there's one thing missing, so you don't have the small wheel, which brings you to the right and the left side. This is a movement you can't have with this probe. And if you want to have the probe maybe for mitral clip or mitral procedures, tricuspid procedures, it might be a limitation. Yeah. So this might be a decision for an institution to go for a real TOE probe rather than going for a minimalistic approach with your
I think that Philips have the lateral wheel. I didn't test it, but I think have it. Mm-hmm. But for appendages and for interatrial septum, I never use the lateral wheel. And we made some mitral clips, but I think that if you are getting the anesthesia, it's better to do with the standard.
Yeah, Marek.
Yeah, Nina, in effect, answered to one of my questions. So for the mitral clip, it's not the best solution, but micro TEE. Another question, are there any cases in which you have to switch back from that mini TEE probe to the standard one because of a pure quality of image, or there were no cases like that?
No, in this series that I presented was only one patient that was not possible to do intervention with the mini, but because he had like a bad reaction to fentanyl and he was super nervous, we tried to do it with the anesthesiologist and he ended intubated because it was even for the anesthesiologist impossible to just put sedation and maintain the patient on the table. And from there, that now maybe we have, with all the intervention PFOs and so, 200 patients or so, was another patient that also didn't tolerate the probe, and that's it. But not because the imaging, because the tolerance, because we do with very mild sedation.
Yeah, and another question, because Philips were approached me this week with 3D TEE probe.
Yeah.
Have you got any experience with that 3D TEE probe from, because that one was from GE, as I understand.
Yeah.
And what about Philips? Philips is good as well?
I don't know because I didn't test it, but in the next months we are going to have it just to test it and just wondering how it works. But if it's similar to this one, I think it will be great.
Yeah, and the last question, with measuring of the pressure, because you have shown a very, let's say, I would say extreme case with enlarging of the appendage after volume overload.
Yeah.
Because I'm not measuring any longer, I'm simply put a bigger device without measuring the pressure. Are you measuring all the time in all the cases, and how often it happened that it increased so much like here? Because in my experience, it usually increased 1-2 millimeters, and I stopped doing that.
Like this, as you say, it's a strained patient, but now we are measuring in all the patients the pressure, but this is especially relevant for patients with paroxysmal AF, and that they are in sinus rhythms. I think if most of the patients with chronic AF, it's not a big change. They used to have high pressures on the atrium, but if you have a patient like this that you see that is highly contractile in sinus rhythms, I think it's worth it to try.
Marek, and just one comment on that. Just not only for measuring, but also for anticipating the risk of air embolization. If you have like such a low pressure, you can even have negative pressures. So you have to be very careful about, sucking air and flashing, wet. So I think that we're doing always, it takes, less than 20 seconds. And I think that it's worth it because you detect those patients that, suck, the blood, and we have had like some cases, and I think that it's really worth it, not only for measuring, but also to prevent air embolization.
To answer the remark from Sergio, it's not only 2 people are using that. I mean, I using this technique, mini TEE, not the 3D, the mini TEE. I've tested the one from Philips. I will let you build your experience. I have my own idea. But I think it improved the workflow in the cath lab, and it was a meeting when Ignacio actually here talked about his experience with micro, and so I shifted directly to this technique, and it works very well actually, because if you have a good pre-planning before, the mini TEE is only for guidance, so you can do that under conscious sedation. We can do a lot of cases within a few hours, and it really improved the workflow in the cath lab. Of course, if you have an anesthetist that works super fast, and you can be as fast as someone using mini TEE, but at the price of a general anesthesia for the patient, which is not always super convenient for the patient also. But the novelty here is that you do everything during the case, because you have 3D. But you need to have your experience to have the same results. So I always think that having still a pre-planning before, if it's available, it's also a plus, but that was the discussion that we had before. But you need to be a super experienced operator that can do, like you, 3D measurements so fast with the patient on conscious sedation and so on. So it's great what you do, and the images are fantastic. But you need to understand all the tip and tricks. Yeah.
Use the same mini TEE pre-procedurally then, is the question.
No. In the echo lab, we use the standard one.
So you don't do the pre-procedural part, echo part there. You do everything in the lab?
Yeah.
Yeah,
Yeah,
okay, that's
we
the
have
point
a
I wanted to make.
screening, especially because we are involved in some studies and we need to
You do
screen.
the pre-procedural with the standard TOE
Standard TOE.
or CT?
What I saw is just in the cath lab, but we used to make also the pre-planning with TOE, but with the standard one, because they go to the regular ECOs in the
And use
eco
the
lab.
macro TOE just to guide the procedure.
But
Exactly.
so my question is, do you still do that? Do you do a classical standard TOE before pre-procedural still, or you skip this?
We start skipping part of this, but as Adele was saying, it's only for some centers with a lot of volume.
Yeah.
But now we are returning to do screening because for most of the studies that we are involved, we need screening. So, but if we have a patient that he lives very far from the hospital, or we think it's frail or not able to be included in a study, we do in the, or a patient that is admitted in the hospital, we do it in the cath lab.
Yeah, good.
So thank you very much, Laura. And Sergio, while you are bringing up your slides, I have one question to the interventionalists. I mean, Laura, you showed a case of a very contractile left atrial appendage. So is this really a challenge for implanting a device, or is it just something which counts for a higher rate of embolization? From an implantation point of view, is it more difficult for you? Why?
And it's in the classification, so we include in the ELAAC classification.
It's in there, but I want to understand
so
why.
it's supposed to be more difficult. So I think, of course, I mean, when you have a permanent AF and it's not contractile, probably the risk of embolization is less. I mean, we can consider that. And also sizing is much easier. I mean, when it's really, really contractile, it's not so easy to have the measurements. And regarding what you were talking, I think that this type of probes change your, not just the procedure itself. I mean, the workflow and the strategy, how you are going to manage this patient. And as Laura said, I mean, you can do it on the table, but the problem is that you need to have an experienced echocardiographer, but also an experienced operator, because you need to have probably all the devices on your lab. So what Adele was saying yesterday, I mean, of course, you can anticipate a complex case, but if you have all the devices on the side and you are the operator and you are experienced enough, maybe in some specific centers, it makes sense to make everything on the table.
Yeah, but the future might be something where we have minimalistic approaches. So, for example, like for aortic valve implantation. So, Sergio, could 3D ICE, 4D ICE could help?
Thanks, Ina. I think that in this session, the approach of this session, the philosophy of this session, should be not a fight TE against micro TE or against ICE, but to have a comprehensive information on all the possible imaging modalities. In the last decade, we learned that the use of 2D ICE provides optimal image for the guidance of LAAC closure. Is a safe and effective imaging tool for the procedure. If compared with TE, we don't need of intubation, general anesthesia, the fast cath lab turnover, and reduce the time of hospitalization with a good imaging resolution. But why should we move from 2D to the 3D ICE? Because there are some technical limitations in the 2D ICE, mainly because the 3D ICE provides super visualization and imaging approach with the addition of MPR or X-plane. The minimal manipulation inside the heart, because you acquire the volume, you block the probe and you walk, because the visualization of the intraarterial septum in a different view is easier, and because to check the final result of the procedure is extremely comfortable for the operator. With 2D ICE, basically, is that it is single plane view. We try to get a surrogate of the 3D ICE with the multiple position of the probe. This is the technology that we have in our hands. Is Acunav Lumos by Siemens. This is the only device available with a CE mark in Europe today. And the VeriSight Pro by Philips, it will be available in a couple of months. And the new Vision, that probably it will be available during this year. Some technical aspects of these new devices. Lumos. Lumos is a 12.5 French single-use device. The volume of acquisition is 90 per 54th, and the high resolution of the imaging in 3D is very, very, very good. And with some technical facilities like the 2D and 3D volume color Doppler, PW and CW, and the MPR on-time reconstruction. VeriSight Pro basically similar, but the French, the device is 9 French. The volume of acquisition is higher, 90 per 90. And in addition, we have live explain and digital steering. The eye rotate is an electronic orientation of the echo beam. And finally, the new vision is 10 French. The volume of acquisition is 90 per 90. And in an independent tip rotation, knock is mechanical rotation of the probe. Okay, but go back to the slide of my previous presentation. How the 3D eyes can address all the points of the procedure. Okay, exclusion of thrombin and pericardial effusion, keeping the probe in the right side of the heart and increasing the depth of view, we can explore the left atrium and to exclude the pericardial effusion and thrombus formation. But one critical step, as discussed before, is the guidance for the transeptal puncture. The position of the probe with eyes is a privileged position because we are in the right atrium, the fossa valli is in front of us, we acquire the volume of the fossa, and we have a perfect and clear and detailed visualization of bicaval and the short axis. So we have all information for a precise puncture. Exactly the same we have using MPR, this is a Lumos. This device don't have the explain, but we can use the live MPR. In one shot we have a 3D and 3 different view in 2D. For the visualization of the LAA, we use exactly the same technique that we are using for the 2D. We advance the probe in the same hole through the fossa. And this is the first great difference from 2D and 3D. We advance the probe in the middle of the atrium. We are in front of the LAA and the fossa vallis. We acquire the volume that includes the left superior pulmonary vein and the ostium of the LAA, and we lock the probe and we walk. Some imaging for the procedure during the pre-implant of the device. We have to reevaluate the main orientation, ostium, landing zone, length, and number of lobes. This is a very nice view of using a through view glass from Philips device. And this is a true view exactly of the same device. In one shot, we have the live view of the 3D reconstruction, and in the left side of the screen, the 3 orthogonal views of the LA. So we have all information for the perfect placement of the device with the perfectly alignment of the device. And this is an imaging from New Vision. The New Vision, the quality of the New Vision is extremely high, especially for the 2D MPR. This is an example of watch non-placement. We see the 3D and the MPR on live with all the visualization, possible visualization of the device. Is a similar image from Lumos. We see in the same shot the 3D and the 3 different orthogonal view of the device and the LA in red plane, green plane, and blue plane. This is another imaging of the New Vision. The information is extremely detailed. We see clearly the cable, the position of the device inside the LA, and is extremely easy to do the tag test and to visualize the presence of eventual leak. And this is very nice use of the MPR. We have in the red plane the lateral, in the green plane the elevation, and rotating the blue plane, we can explore 360 degree all the circumference of the device for the checking the presence of leak and interrogating with the color before the final release complete all the information that we need for a precise placement of the device. This is the last image of the Lumos. It is a 3D visualization of the device with NPR and 3D volume reconstruction interrogated with the color for checking the presence of the leak. Okay, my conclusion that the ICE is a safe and effective imaging modality. We don't need of the general anesthesia. We don't need an additional physician for the TOE. The 3D ICE is less traumatic, easier to handle. It requires fever manipulation and improve the quality operator control and comfort of the operator. The 3D ICE is the quality of the imaging is superior for a greater procedural precision, for an accurate device deployment to reduce the rate of complication and to optimize the outcome of the procedure. Thanks so much for your attention.
I mean, Sergio, we might go deeper into the discussion after we've seen some cases from Jens-Erik. So Jens-Erik, if you would come up. But one question, Sergio, who's handling the ICE probe and who's handling the echo machine?
In our center is the interventional cardiologist that manage for this kind of procedure, that manage the ICE probe, and is the sonographer manage the machine. For other more complex procedure, like for example the tricuspid, we have a dedicated imager to manage the probe. I think that in the next future, my personal view is that we need a dedicated interventionist imager dedicated to the procedure. That is because we have to go ahead for the use of new imaging technology, but we need of the experience of the imager. It's absolutely needed.
So any burning question, or we continue with you, Jens-Erik, and you give us some insights and some real cases?
Thank you. So this presentation is not only about intra-procedural imaging, it's also about a new device, the Conformal device. It is out there in its second iteration, and it's now called the Accuform device. So this is the concept of this device. It is a foam-based device, so it consists of a foam cup that can actually conform to the appendage anatomy and wall, and then it has an endoskeleton that is open in its end, and it's very, very flexible. Over this foam cup, you have an ePTFE membrane, and this is, of course, giving a smooth and also thromboresistant surface, and as you will notice, there's no metallic hub here, there's no screw end. So the way that you are in attachment with this device is by means of a suture or a tether that you can see on the right-hand side. So, and if you look at the device from below on the left-hand picture, you can see the central part. There is a pin, and I cannot mark here, so, okay, there is a central pin, and that's where the tether is attached.
Jens-Erik, you can use a pointer and show it maybe at the screen.
Okay. Yeah, it's working. Okay, fine. One thing also with this device, that the height of this device is actually down to 10 millimeters, and this gives us with this device an opportunity to implant it when we have a very limited depth. But also the idea with this device having a very conformable, flexible endoskeleton and this foam covering it is really to come down and not have a a large range of different device sizes. So actually this device only comes in two sizes, a regular size, which has a diameter of 27 millimeters, and also then a large device which has got a diameter of 35 millimeter device. And with those two devices you can actually cover a full range of appendage landing zone diameters coming from 10 up to 40 millimeters. I think a very nice feature with this device is that it can conform to different anatomies, and especially to also oval anatomies. You can see how this works in an in vitro model. Some of the devices that are out there as our mostly used devices, when we compress them, they more or less stays in a circular shape. But with this device, if you compress it, you can really get a oval configuration of the device in order to really conform to the anatomy. The device has some anchors here. Initially the anchors had a higher length of 1.5 millimeters, and in the first generation with this device there were some pericardial effusions, probably caused by the length of the wire. So in this second iteration of the device, the anchors are down to 0.75. There are also some changes to the device handle. In the middle you can see the device handle here, and this is very intuitive, where you can control the suture or the tether of the device by stretching it out or having slack to the suture. So this shows how it comes before you load the device. You have to load it into a device catheter here. It comes here. You cannot have it preloaded. It will damage this foam cup. So you have to load the foam cup into the device catheter, and then you have, like with the Watchman system, you have an access sheet or a delivery sheath, and then you can put your device delivery catheter inside the access sheet. So the whole idea with this device is to have high conformability, to have low thrombogenicity, high degree of sealing, and also a more simple way of choosing the device, and not being maybe so dependent upon imaging. We have been involved in Europe in this device in a trial where we are going to put in or implant this device in an ICE-guided workflow. And this is our usual workflow, that we do a pre-procedural CT, typically the day before or at the procedural day. Then we guide the procedure by 2D ICE, and we make follow-up CT scans after 45 days. And we are still there left with the standard of a 2D ICE. MDR approval has obstructed our use of a 3D probe until probably, hopefully, within the next few months we will have availability to the 3D ICE probes, but not yet. So with this study we are using the 2D probe, and we have developed, as you might know, some standard views. The left upper pulmonary vein view, the ICE probe is just in front of the left upper pulmonary vein. We can visualize the LAA, the mitral valve. If we take the catheter a little bit down towards the mid portion of the LAA, we can also, by a little bit of counterclock rotation, get an image of the LAA and a cross-sectional view of the aortic valve. And then we also do the supramitral view. So we rotate the probe and put posterior flex to it, so we visualize the appendage from below. And we get an image here where we can have the LAA and also the pulmonary artery. So the first term here is the device ICE catheter position, and this is what we view with the three different views. So this study is called the GLACE study, and it involves 80 patients, and it's done in Aarhus, Copenhagen, in Massa in Italy, and also in Prague. And I will show you one of the cases here, a 70-year-old male, prior ablation, prior subarachnoidal bleeding, coiling of an aneurysm giving rise to this bleeding complication, and definitely a patient that was unsuitable for anticoagulation. So it's all clinically indicated LAA cases that are done with this conformal device in the GLACE study. Pre-procedural planning with cardiac CT, you can immediately appreciate here that we have a kind of reverse chicken wing anatomy with a quite limited depth here. And this is the true plan software, going to this and getting a cross-sectional view in 2 planes in the MDR view. It will give us the landing zone. And the landing zone for the conformal device is like the flex device. We have to land the device at the level of the circumflex, being perpendicular to the axis of the appendage. Orifice here 21 and 14, and a maximal depth 16 millimeters. And also importantly, as we have talked about, we choose, I can go one back, we choose our C-arm position based on our CT planning, so we know that we are looking at the landing zone, and then we are perpendicular to where we want to land the shoulders of this device. So the angios looks like this. We do also have a straight lateral projection here because we have a biplane lab. It's not necessarily, but it's nice to have. So here is images, eyes images from the left atrium towards the appendage, and when you do deploy this device, you start to fold out the distal 5 millimeters of this device. This is simply foam without any hooks or anything. It's completely soft. So this corresponds to the ball shape of the flex device or the ball shape of the amulet device. This is the working position of the device, and you can then put it deeper, or you can rotate it and manipulate with it. So that is the angiographic picture, the fluoroscopic picture of this bumper region, the distal 5 millimeters, and you can also appreciate the very distal margin of this device by those markers, radiopaque markers, and you have a radiopaque marker at the level of the shoulder. So from there, when you have, based on eyes, a good position of the device, you start to deploy the device, which is seen on the left-hand side. In this case, you can actually see that we have a situation where the device doesn't really is aligned now to the axis. The axis of this appendage was towards 2 o'clock, and you can also appreciate by eyes here that you have an uncovered area here, and the device is tilted. So that is a challenge with the device because of the height of this device, which is only 10 millimeters. So it's extremely important that you are coaxial with your sheath to the axis of the appendage. And actually, we have now a steerable sheet. That is the latest iteration with this LAA closure system, that it comes with a steerable sheet, so we can make this alignment perfect. But I was not happy with this, so I took it back, and you can appreciate that the sheath is now rotated more counterclock. It's pointing more like 1 to 2 o'clock, and I'm deploying just by resheathing the device, and there's a better perpendicular position of the device to the landing zone. And you can appreciate also on the images that the region here where the tether is connected, it's central to the ostium here. You can do the tuck test easily by this suture, and it has this advantage that there's not a cable that actually controls or interferes with the position of the device. The device can be evaluated by having slack to the suture, what will be the final position. And on intracardiac echo, you can also appreciate this tether, and you can you see the tucking on the left. To the right, it's only the tether, but it can also be nicely seen on ice. So before the release, we have to go through all the criteria, also the sealing criteria. And one thing that is nice also with the device here, I'll go one back, is that you can do angio here on what is called the pusher catheter, and due to this EPTFE, there will be almost immediate sealing with this device. Before final release, we have to go through all the 3 ice positions. So this is a supramitral view, looking at the conformal device, and again, final angio here for the second deployment. And to the right-hand side, the tether has been released from the device, and that's the final position. And patients come back 45 days after implant, and this is the appearance. Maybe you can go one forward. No. I missed the last slide, but anyhow, it looks on 3D CT follow-up. We have done so far 10 implants, and it looks like we get very, very nice sealing with this device so far. Thank you.
Thank you, Jens-Erik. You put the accent on 2 very important aspects of these new technologies: the conformability, because during the procedure we have to adapt a very regular geometric shape of the device to a very irregular shape of the ostium. And the other, the biocompatibility, we discussed yesterday, the TRT, the complexity of the implantation, etc. One of the aspects that I want to discuss with you is how it's important to be coaxial, because you showed that to get the best coaxiality is very important. And what are the radiological and echocardiographic marker that you observe before the complete release?
Yeah, it is very, very important that you are coaxial, because if you come in another angle, there's a tendency that this device can rotate. So you have to do your pre-planning, you have to choose your optimal C-arm, then you know what you're looking at. And you also need, with 2D eyes, to have 2 orthogonal planes, so you need to evaluate the device position both from the mid-LAA and also the supramitral position. You get also information from, I didn't tell you that, but I can say it now, something that is also nice with this device, this endoskeleton, it is laser cut from one nitinol tube. So the very proximal area of the device where you have the pin where the tether come in, it's just, so to say, the very proximal part of this tube. Everything else is laser cut, even the hooks. And when you look, you know when you are totally perpendicular to this area, because then the hub is just a flat line. If you are not perpendicular, you will see it like a circle and the pin in the middle. So
it's a radiological marker of perpendicularity. Yes, is correct.
Yeah.
Okay.
So Jens-Erik, if I understand correctly, so the frame is much softer compared to other devices. So you're not using any amount of radial force to anchor the device. So what is your strategy in sizing? Can you oversize it more than other devices, or do you do that?
I think that it is more, definitely, you only have two sizes, so it's much more forgiving in relation to your pre-procedural sizing and the actual landing zone dimensions. But if you just want to go, you could imagine that you could go for all the cases just with the largest device. But there is a limitation, because if you have a small appendage and the large size of the conformal device, there's a risk that this foam cup can fold and make small channels. So you have to discriminate whether you have a large or a normal sized appendage, I would say. But the experience until now is that I think up to 90% can be done with a regular size device, and it's only about 10-15% where we go to the large size of the device.
Okay, Tom.
Thanks for the video. I like the case in the example you showed. I think some people would like to put a device as proximal as possible, and if you would do it with a plug design, it would result in a shoulder towards the mitral valve, and then people would say it's acceptable, you can have a shoulder. With this design, given the short landing zone, is a shoulder okay? And given the fact that maybe it's much less vulnerable to DRT, do you think this design is more forgiving if you stay more distal? Do you think it will change our practice of implanting, or would you also go for a shoulder if it happens to be the case?
I think it's rare that you get shoulders here. I mean, you really aim to position the device where you have the circ and are perpendicular to the axis of the appendage. And due to the limited height, I think you can achieve that in most of the cases. And also, if you start to see a shoulder with the height of only 10 millimeter and the anchors is within the height of 10 millimeters, you will maybe also start to get some less stability of this device. So I don't think that is something that we are going to see with this device, that we are having shoulders. And I think also it will apply that we shouldn't go for a deep implantation. That will be totally the same. We don't want to leave an area with slow flow in front of this device either. So, but I think it's an innovative device. There are new thinking in this device, and also the simplification of two sizes, if it really works and creates sealing in most of the cases, it's quite attractive, I think.
Can I make a question, Sergio? Yeah. About this time is a question to Sergio about the 3D. Do we need to go to the left even with the 3D with a new probe, or can we stay on the right and look? Second question is which is the size? It's always we need a 9 French introducer for the probe.
Okay, for getting a good visualization with the eyes in general, but in particular with 3D, we advance the probe in the left atrium, and the main advantage of the 3D is that you don't need to manipulate the probe in different position, supramitral, as Jens Erik showed, or in the middle atrium, left atrium, or the ostium, left superior pulmonary vein, but you pack the probe in front of the LAA, and you lock, and you acquire the volume, and then you do everything electronically, so it facilitates the procedure. And what's the second question?
The size of the introducer?
It's bigger, or it depends, because the Siemens is 12.5, and usually we use half French more of the just to facilitate manipulation, and the Philips is 9 French, and the Novera is 10 French. But I suggest to use half or 1 French more for facilitate the rotation of the probe, even though the manipulation of the probe is extremely easy because you need 2-3 position in the heart. Yeah. I have a question for you. The last question, Jens Erik. I understood that the pre-procedural planning with this device is essential. Is correct?
Yes, I think it is.
Oh, and the second question is the alignment of the device is a critical step. How would be important to use a 3D view? Because you use the single plane intracardiac echocardiography using multiple views just to surrogate a 3D views.
I think that will be very helpful. I mean, if you have a en face volume reconstruction of the orifice of the appendage, and then you will be able to see exactly the central part where the tether is inserting into the device, and you will be able to evaluate easily if you have tilting or not. So I believe that that will be helpful, and also for interrogation of leaks, I think a 3D concept is more attractive than what we have with the 2D eyes, of course. So it will be very interesting to look at this device also with 3D eyes.
Ole.
Yes, Sergio and Jens-Erik, having a little experience with the conformal device, or the ACU form, or how you call it now, indeed, it's the fact that the device itself is extremely soft. There's no big skeleton, like a robust skeleton like we're used from a Watchman Flex or an amulet. And you have that tether, you don't have a cable, that makes that you're totally dependent, and it's a strange feeling as an operator in the beginning, I have to say, that you're totally dependent on your sheet. Your sheet determines everything. Because the device is so soft, you have a tether, which is not, I mean, it just hangs on a tether. So it's the sheet that really determines exactly where this device, how you deploy it, where that device is going to sit. And it's a feeling I had to adapt to, I have to say. So it's something different. It's counterintuitive from all the other devices. So yeah, there is a learning curve, I'm sure, in it. And that shows indeed that for them, probably a steerable sheet is really key. I mean, if they don't have a steerable sheet, probably in majority of cases, well, you can put a device there, and it's true, the follow-up from leak is like, it's extremely good sealing, but now they're limited in how you can position the device without a steerable sheet, and then you sometimes have to be happy with a really distal implant, yes? But I think it could be optimized. They are so depending on having good coaxiality, because you don't control the device with anything else. So if they, and now they come with the steerable sheet, then I think it could be a real good option, yes. Yeah.
Thanks. We have more question. Just a very short question.
Yeah, sure.
In case of an embolization, how do you recapture or capture this device?
Yeah, actually, we have tried that. So it's not, yeah, you are right, you don't have any hub to grasp, and you could imagine that you took a grasper device, but it's also a little bit probably risky, because you can maybe damage the foam of this device just by grasping to it. At least then you need to grasp into the endoskeleton. But what you also can do is that you can put a PCI wire through the endoskeleton, and then you can make a loop with the PCI wire, and you can get it out in that way. That's a possible way. But it's a good question, and it adds to the discussion that we had yesterday. You have to make some consideration for every device, how to get it out, what should be the sheet size, etc.
Jens-Erik, a very stupid technical question. So your case study was already included, or?
Yeah.
Okay.
Okay.
Any further questions? I mean, it's a super interesting new concept.
So it's also my pleasure to talk a little bit about the future of a 3D ICE catheter. And I will say that this technology has been underway for many years now. Actually, it is more than 5 years ago. I had a visit from Philips, and a group of Philips engineers that had the task of creating a 3D ICE probe, and they studied our workflow, and they studied the image quality that we have with the ViewFlex and with the AccuNav catheter, and I also had an opportunity to give my input to the design of this Philips 3D ICE catheter. And I have been struggling ever since to get it into my lab, and I didn't succeed at this moment, and only within the next few months I will have this catheter. But I can talk a little bit about it and how I will imagine that it can be helpful for left atrial appendage closure. So again, this is the workflow we have: pre-procedural CT, ICE, and then follow up by CT. And you already saw that when we are utilizing the 2D ICE, we have to cross the intra-atrial septum, we have to go to the left upper pulmonary vein view, we have to go down to mid-LA view, we have to rotate 180 degrees and put a lot of posterior flex to get the supramitral view. But we have demonstrated that we can utilize this technology and get the same results as with transesophageal echo. But it involves manipulations inside the left atrium, and there is a learning curve for ICE, and there is also US data showing a little bit higher pericardial effusion tamponade rate in ICE-guided procedures, and of course it can be traumatic to maneuver the catheter inside the heart, so that is a potential drawback. So, additional to the two catheters that are showing here, the Philips VeriSight and Nuvision, you also Sergio showed us the Siemens catheter, but I think it is a little bit different because it's a 12.5 French device. So with this technology of the Philips, we are really down now to 9 French, which I think is important if you still want to go into the left atrium, because we have to cross with both an ICE probe and also a delivery sheet. So I like that it's at least down to, it's bigger than the 2D devices, at least the AccuNav, it's the same dimension as the ViewFlex, which is now our current use. This is the design of the catheter. It can be steered anteriorly, posterior, left, right, as the ViewFlex catheter and the AccuNav can, but you have much more crystals available here, arranged in this rectangular device, rectangular setting here. So you have 15 versus 56 ultrasound crystals. So you have a matrix, and then you have the possibility to do multiple views just from this arrangement of the ultrasound crystals. And that is demonstrated here just by a digital steering that we all know from TE ultrasound probes. We can get biplane imaging and we can get multiplane imaging without maneuvering the catheter itself. And I think it's quite amazing that we now have a technology built into a 9 French dimensional catheter where we can get images like this. We can get the 3-dimensional rendering views, and we can get MPR views. I think it's fascinating technology. So for me, the transeptal puncture will be easier with 3D ICE. You can, without also manipulate the probe, you can get longitudinal, you can get cross-sectional views. I also expect that we putting this catheter into the left atrium can avoid many of our current catheter manipulations to do all the views. We can use digital steering instead of mechanical steering. And I'm really excited by the possibility that we might position the catheter just in one mid-LA position, and from there you can get all your views. I think we can get an improved anatomical understanding of the left atrial appendage by this technology. We can do sizing by MPR, and it also asks the question if we in the future can maybe skip pre-procedural imaging and go directly to a 3D ICE-guided workflow. I think along with intracardiac echo, it's extremely important that we make sure to get very good education and support. And I will say that this has been part of the Philips preparations for launching this catheter. They have a very, very nice imaging protocol and teaching materials. And I also know that they will really prioritize to get good support when we start to use this catheter. But this is an illustration that you can just move the ViewFlex catheter to the mid-RA position, and you can rotate until you get the bicaval view, and from the bicaval view you just make a 45-degree steering so you get the short axis view. So you have this, as you know from TE, a view that is very important to guide our transeptal puncture. So this has become much more simple. As we do now, we do get the septal view. We have to rotate clockwise to see the posterior part, rotate counterclock. Now we just keep it in the same position and we do digital steering. It has, as it is now, developed so that we can guide left atrial appendage closure from the left atrium. There was this question, can we just stay in the right atrium and get everything from the right atrium? And I don't really know. Probably image resolution is not that good, but it's still something that we need to explore, the possibilities with this new catheter. Can we really stay in the right atrium and maybe have sufficient information? I don't know as it is now. But again, if you position your ICE catheter inside the left atrium in one position, you can use 45 steering in one direction and 45 degrees in the other direction. So you have orthogonal planes here. So you can get the LAAPA view and you can get the LAA aortic view. So at least theoretically, you can totally obtain what we do by mechanical manipulations of the probe. We can get the LAA mitral valve view, the LAA aortic valve view, and the LAA pulmonary artery view just by digital steering from a position mid-LA looking fast into the left atrial appendage. And this is what will be the sort of equivalent TE projections. So it's shown here. That is the view that you can obtain from a mid-LA position, having a view of the LAA and the left upper pulmonary vein and the mitral valve just by steering 45 degrees. You can obtain a cross-sectional view of the aorta. And if you steer the opposite direction, you get the orthogonal view of here the LAA and down here the pulmonary artery. And I think that is also the evaluation of sealing by color Doppler instead of moving around and looking for color Doppler jets, etc. You can stay in the same position and you can again have neutral. You can have 45 degrees steering in one towards the aorta and towards the pulmonary artery. And you can of course also apply the three-dimensional views here. Here also illustrated with a flex device where you can obtain a fast cross-sectional view of the device, and you can really measure the compression, the percentage compression of the flex device. So this 3D ICE catheter from Philips has been available in US for a while, and this is the first study from the Mayo Clinic that was one of the first sites to obtain or to implement this new catheter, and they have demonstrated in this cohort of 100 patients that it's feasible to use ice. They actually started out by using both a mid-LAA position and also a supramitral position, but it's really my hope that we can reduce it down to one position in the left atrium, the mid-LAA position, and from there get adequate views. But you can see that the results according to clinical outcomes and leaks, etc., it's the same as, for instance, the Pinnacle Flex, which was TE guided, the ICE-LAA, which was 2D guided. So it's definitely feasible to use this new catheter. So it has the potential to improve the guidance of our transeptal puncture, that we can have less catheter manipulations, that we might have a single position inside the left atrium. We get a better understanding of the device position, as we talked about, aligning the device and the sheath to the axis. We get an improved diagnosis of leak, improved understanding of LAA. Can we avoid, with this technology, CT pre-planning? I think that's something we should test in systematic studies. I think there will be a faster learning curve with this catheter compared to a 2D strategy. One potential drawback is that the manipulation or the operation of the ultrasound machine might be a little bit more complicated as it is now. One of my nurses is just maneuvering the echo machine, and there will be a little bit more maneuvering and teaching demands for this. And also I would be very, very interested whether we might come down to a strategy where we just can use this catheter from the right atrium. Maybe if that is our workflow, we'll have to combine it with the CT, a pre-procedural CT scan. So I think there's a lot of new options with this technology that we have to explore in the future. Thank you.
Thank you, Jens Erik. Question from the audience? Yes, a lot of questions.
You and Sergio beautifully showed the benefits of this technology. I missed a bit, I think, the biggest challenge, which is finding the budget to use it, of course. And knowing the cost of regular ice, I'm a bit afraid to ask, but I'm going to do it anyway. Do you have any idea of the disposable cost of these catheters?
No, I think that's a very, very good point, and we have to ask Philips for that. And one thing that is also, in my mind, a little bit meaningless, that we have single use of catheters that are so advanced like this. Throw it out from after a single use, that make no sense. It has a very smooth surface that can be re-sterilized, and we have been struggling in Denmark to actually get allowance to re-sterilize catheters, and we very recently from the authorities, the health authorities in Denmark, got approval for re-sterilization, but with the requirement that we are using a professional company. So we have to send it to Vanguard in Germany, and Vanguard takes at least 1/3 of the catheter price for re-sterilization, but it's, it will be, I think, a limitation can be economy, of course.
Yes, probably I think this is the main limitation of this technology. Savi?
I had more or less the same comments. Very few countries in Europe could afford to use this catheter as a single-use tool. But actually there is a trend in many European countries towards the ecological transition to authorize the re-sterilization of the catheter like this. Although catheter cannot be reused, but this type of catheters, like EP catheters, probably are going to be authorized for multiple use after re-sterilization. There are different processes that can be in-hospital re-sterilization process, or that can be I mean, outsources by specialized company like you mentioned, but this is definitely the way we must seek, because there is no point in Europe to use these catheters as a single-use tool.
There are two open questions. One is the regulatory, and the second is the experience with the 2D eyes is after the second sterilization, the quality of the imaging tends to be worse.
Yep. Two comments. So I've done about 20 cases with it, and that from the RA you don't get enough resolution, and with the mid-LA, usually in most of the cases it's fine, but there's interaction with the regular sheath, and sometimes the better working view is the supramitral. The other thing is, and I shouldn't be saying this publicly, I may have not thrown out the probe and taken it as I work with Conformal, and that there is an interaction with the machine. When you click it in, it kind of knows that you've used it before. So Philips is thinking about this, and there is a degradation of the images once. I don't know how our engineers figure out how to get around that, but this should be able to be reusable, and the price is way too expensive.
Okay, the last question.
We use eyes sometimes, as Sergio taught us, and in my experience, we cannot see properly the depth of the appendage. Therefore, in order to answer one of your question, for me, the pre-planning is mandatory because of that.
I totally agree with, especially with 2D, but the question is if we now with 3D can skip pre-planning in some case.
I suppose that the sentence of Jens Eriks, it can replace with the question mark was a provocative question, I suppose.
Yeah.
Okay. Okay, now, thanks, Jens Erik. Okay, now it's a great pleasure to invite Nina as how to match ELAAC criteria, TEE and CT.
So thank you very much, Sergio. I mean, what we heard is that the ELAAC criteria are based on CT imaging. So how do we match the ELAAC criteria in CT and TE? And can we use the same criteria if we use TE? And how do I apply the criteria in clinical practice? So if you look at the anatomical determinants, which can tell us, well, this will be a more complex procedure. So we have transeptal puncture. We have to evaluate the entrance, which is the E for ELAAC. We have to evaluate the landing zone, the overall anatomy, the axis, and the contractility. And I will show you that most of these can be covered by TE. The only thing we can't offer is the perfect fluoroscopic plane, which you can use for your implantation. So let's have a look at transeptal puncture. So this is not in the ELAAC paper, but I think it's a very important determinant for success. And TE can help to get you some impressions if you have, for example, on the left-hand side, a very floppy septum, which can make your transeptal puncture more difficult. If you have a real huge bulging towards one of the atria, as you can see in the middle, or if you have a patient with a scoliosis, which makes your transeptal puncture more difficult, because this can lead to a higher rate of mispuncture and pericardial effusion or tamponade in some of the patients. This is also something you can evaluate with TE. So this was an interesting case because this was a development of a thrombus in the left atrial pouch of a closed PFO tunnel. And this is something you can evaluate, and you can easily imagine if you find something like that, it can make your transeptal puncture more dangerous for the patient. You can have a stroke. And just to show you that it was really a thrombus, so this is the same patient 4 weeks after anticoagulation therapy, and you can see the resolving of the thrombus in this situation. The long pulmonary vein ridge, I think this is something which is very easily accessible with TE, and I just bring you a couple of cases. So this is a little bit unbalanced because you only see Watchman cases here, but this was for a study. I could show you the same images for AMOLED devices as well. But here are a couple of images where we have this issue with a long pulmonary ridge and a thrombus formation in the patient. Large ostium dimensions, I don't know about your experience, but this is the only case I found in my database which really had such a large ostium. This was 40 millimeter. And you can get an impression because this is 34 millimeter carpentry ring in place, and you can get a nice imagination how big the ostium of this patient is. But this is the only one where the ostium exceeded 40 millimeters that I found. So what happens with these patients? So it might be, so like in this case, we don't have an appropriate device available to close this left atrial appendage, and we might have a higher risk of PDL formation and embolization in such cases. So proximal tuberculations, this is something we are not good in if we use TE, because this is something we usually can't see. But as you can see here, it becomes very obvious that something like this, if you have tuberculations here outside of the ostium, this could lead to a higher percentage of thrombus formation in these specific areas. So this is something we are not good in, so we can't really say that. A low takeoff or short distance to the mitral valve, so this may happen, and I frequently see it after mitral valve repair, for example, and the distance from the left atrial appendage ostium to the mitral valve becomes closer. So I brought you one example, and you have to believe me. So this looked a little bit better directly after implantation. So this is a LAMPR includer. We have additionally a very short distance here, which is not perfect for a LAMPR. But the disc right after the implantation was at the ostium. But look what happened. So this is a follow-up after 3 months. So this disc is now interacting with the mitral valve. But it's the only case I found in my database where we really had an interaction of a device with the mitral valve. But it can happen. So the next thing we have to look at is at the ostium. And so we could have cases, for example, with a proximal membrane. It's rare, but can happen. So in this case, for example, the entire orifice is nearly occluded. So you could try to implant something below, but you really have to think about how to implant your occluder. Another example where we have a proximal membrane or a protuberance, whatever you want to say to such a thing. But this may, because it's asymmetric, it might affect the final placement or final position of your device. This is maybe more simple. I mean, it's specific, but this is something we don't see unrare. After a surgical repair, you have to take into consideration, if it's a suture ligation, that you have residual shunt in about 30% of the patient. So this is usually a nice proximal positioning because, I mean, you have a nice circumference, you have a nice landing zone, so this is usually not that difficult. And like in this case, so this was closed with an amplet occluder, a small amplet occluder. You could also use a plug, but usually you have a nice landing zone if you have cases like that. So this is the same example. It wasn't only the ostium, but also the landing zone was super large in this patient. So this was a patient where we had no real device available to close this appendage with a nice landing zone and super huge and large ostium in this patient. High eccentricity. So this is an example which can be easily detected by 3D imaging. And we know that in very eccentric configurations, it might be more frequent that we have peri-device leaks in a specific scenario. A proximal bifurcation, I think this is a real issue, and you have to think about the device you're going to use. So this is one of my cases, but it's an old one. So this was a case where we had 2 lobes and a very high rim in between. And you see what happened. I mean, a watchman was placed in one of the lobes, and we couldn't take it out. I mean, you don't want to leave a device like that. So nowadays, you would look maybe for a specifically designed device, for a LAMPR device, but it's not an easy decision how to implant your device and how to make a decision in such a case where you really have such a proximal lobe. So you have a higher risk in these cases to leave an uncovered lobe or an unsealed area. So this is another case. This is something I got for review. And I think you are all super experienced, but we have to think about the people who are doing procedures outside of this room. So this, for example, was a case where you can see a proximal lobe here. And I would have thought, okay, this is easily or can easily be closed with any kind of device, but you have to stay into the axis of your main anchoring lobe. But you see what happened. So the landing zone here was around 22, and a 22 millimeter amulet occluder was chosen, a little bit too small for this scenario, maybe. And you see what happened. So it was implanted in an oblique way, and it opened up completely this proximal lobe. So this is indeed something which can happen. I mean, maybe not in this group here, but it might happen, and we have to think what we suggest, because the people outside who have less experience than you might run into problems like that. So large pectinates can be an issue, or protuberances, as you can see it here, because it might lead to a situation where you have an unstable device position, or maybe some areas which are not covered by the device, and this is also very easily accessible by TE. An early sharp band, a chicken wing, and it doesn't matter if it's anterior band, like you can see it here, or if it's a posterior band, you may have a higher chance of an off-axis implantation and a higher risk of PDL. So how could we define the transeptal puncture? So I think we all agree we should go for an inferior puncture, but how can we tell if we should be more anterior or more posterior? And I think it's very easy, because we can get wide angle acquisition, and you can easily get the impression where your septum is, your interatrial septum, in relation to the ostium. And if you would draw your translation a little bit lower, you can also follow the axis of the left atrial appendage. And to make that a little bit clearer, so 2 examples, for example, here you have the level of the interatrial septum, which is indeed a little bit more anterior, but the origin of the left atrial appendage, the orifice, is on the lateral side. So this is not such a difficult case. But if you look at the case on the right-hand side, you have an anterior position of the interatrial septum and a very anterior position of the ostium. So in this case, if you go for an anterior or mid-fossa puncture, you'll run into trouble. So it might be really crucial in such a case that you really go for a posterior puncture. So this is just a case from Adele. So this is a combined complexity case. So you have an early sharp band and you have a shallow limited depth for implantation in the specific patient. But Adele was able to close this very nicely, actually, because it was a really difficult case. So cases like that, funnel shape, fast tapering, this might be a difficult case because you have to look for your landing zone, and you have to make sure, for example, if you use a double disc device, that you really cover the ostium. And it might lead to a situation where you have some uncovered proximal areas, and again, a higher risk of maybe a per-device leak. Shallow implantation, this is indeed, I think, one of the most difficult situations. And if you run into a situation like we see it here, you don't only have a short depth for implantation, but you also have nasty, stiff pectinates like here. So this was a case where it took 8 attempts to really implant finally the device. So this is something which contributes to the complexity, definitely, as we can see it here in a TE example. So this was one example. Again, will not happen in this group, I'm pretty sure, but again, a case for review. So this was a left atrial appendage with a very short pouch-like, very unusual location here. And so a 20 millimeter Watchman occluder was implanted here. And you can see the device is extremely squeezed. Yes, so compression is more than 50%. And it's not the fault of the device. I mean, it was just overestimated. And what you can see here, so it's a little step here, and you can see the flow running through the device. So this was something where you had a situation where you had a low implantation depth and created something like that, which caused a fracture of the frame and an intracardiac shunt, let's say. So this is also not a very nice situation. And because something which is not expected, because I would think this is more a peanut than a hot dog, so this is not an acceptable compression. This is an homage on Ole, and to demonstrate that the ELAAC group is really democratic, because we decided to get rid of fauna and flora. Okay, so the seahorse, unfortunately, is not in the classification anymore. But I think what should be mentioned, I mean, you can have a left atrial appendage which has multiple protuberances. Okay, and this is maybe, Ole, what you would call a seahorse. Okay, but it's not in the classification. Contractility, this is very easily accessible. If you just look in an office view on the office of the left atrial appendage, you can also do 3D measurements, MPR measurements, and measure your contractility. So this is something which can be easily assessed. So this might lead to a situation where you have a higher risk of embolization. And this is something you have already shown. So I think it's easy also with TE to follow the classification. It's not only something, it's not something which is really reserved for CT, so we can translate it. And each of these ELAAC criteria increases the complexity and can potentially lead, and we have seen some cases, and can potentially lead to suboptimal results, as we've seen that. And when multiple ELAAC criteria are present, so we could assume that the complexity increases further, which may have additionally negative effects on the outcome of the patient. But this needs validation, as we already discussed. Thank you for your attention.
Thanks, Nina. Question? What is your opinion regarding the use of physical model with, for example, 3D printing to check the matching between the TE and CT?
I think there's one downside with CT and with CT printing, because you never get a real idea of the quality of the tissue and how the tissue would behave in such a situation. Especially if you have protuberances. I mean, we all made this experience. Or if you have pectinates. So in some cases, it might be very easy to push the pectinates down and implant your device. So in some cases, for example, as in the example I showed, the pectinates are very stiff. Yeah, so tissue quality is something which is really important, I think, and how it will conform to the device. This is not predictable with pre-printing, with CT. So this is something we really have to experience and observe during the implantation with an adequate imaging modality. It can be TE, it can be ICE, it can be a mini TE, but this is something we only experience during the procedure.
I have a question to this ELAAC classification. Because from yesterday's presentation, I thought that classification could be used also by, let's say, centers which use CT and TE. Now I understood that in that classification are only examples from the CT. So that, in my opinion, limits the usefulness of usage of that classification in everyday clinical practice, because some centers will thought, if I am not doing a CT, these criteria are not applied. What you have, Nina, showed us, it's that it can be used by both TE and CT. So why not in the paper there would be examples of the CT and TE showing that classification can be used by both pre-procedural imaging modalities?
I mean, it can be transferred one by one, but I give this question to Adele and Jens-Erik.
No, I would really, I enjoyed this presentation, and it has not been our attempt from the beginning just to have a classification where CT was the reference. And I think Nina excellently demonstrated that all the morphological criteria can be recognized on TE, and we could have had this in the first edition of this paper, but in some way we cannot have it all. But this is a very, very logical outcome also from this meeting, that we will have a follow-up publication where Nina can demonstrate with all those examples. They are extremely nice in a paper that it can be applied also, this classification, to centers that are only using TE. I think that will be extremely important to show that.
Yeah, I think the main thought behind the classification is not how we use it in CT and TE, but just to get a standardized view what to look at and what are the thresholds. Yeah, and I think if you use CT or TE, it doesn't really matter, because we can get and come to the same conclusions.
And I think it's a very important point, because we have still kind of two schools, one that is using CT, one that is using TE. And also when we come later today to talk about DRT, leaks, etc., I think it will be extremely important if we can have some common language and some common outcomes that applies both for CT and for TE.
I mean, this is a strong CT community. So who's using TE beside me? Oh, thank you. There are a couple. I get support, Jens-Erik.
Okay, thanks, Nina. It's time for the consensus and future perspective, I invite Ignacio.
Thank you, Sergio. So we are late again, so I will make a quick summary of what we have discussed during this session. So Laura has presented the 3D and 4D probes, a game changer, and I really think that we should agree that can be a game changer. I'm totally biased with this because I have been using the micro TEE probe for the last 6 years now. So we describe our initial experience. We participate in adults multi-center European experience, and we have published that this is not just a problem of procedural imaging. It's a problem that we changed our strategy. So now we are using a minimalistic approach for the last 5 years. So it's same-day discharge, just one venous access, and mini TEE probe, so you don't need general anesthesia. The patient can be discharged the same day, so it's a totally changed way to do things. But we are still using pre-CT as Jens, and we have discussed a lot about this today. This is our current strategy. So pre-CT, the procedure is always done with mini or micro TEE probe, and I said same-day discharge. But probably with these new probes, as Laura has just shown, we can consider screen the patient on the table, and we can take again measurements, we can do 3D guiding, and probably we can get a better evaluation of the results. So it's something that we can discuss if we can take out of the equation the pre-CT if we are using this new 3D and 4D probe. Probably is what we are planning to do. We have just begun to use the 3D probe, so maybe it's something that we can consider. After that, we have seen how to use and how are the quality of image of the 3D and 4D ICE catheters. So Sergio has shown us that this type of catheter, of course, has a superior visualization and imaging compared to the 2D imaging. Also, what is nice is that you have minimal manipulation needed. That is something that I really feel that is important, because there are some centers that they are not willing to use ICE catheter because of the manipulation in the left atrium, so this can make a big impact. And also, it's quite easy to see the intra-atrial septum, so transeptal punches should be safe. In this sense, I yesterday presented, this is a document of in US, so it's an structural heart imaging using 3D intracardiac echo, so it's a position statement, so I think it's a current situation that most of the centers are willing to use this, especially in US. Limitation, because I think that the title of your talk, Sergio, was advantages, but I didn't see any disadvantages. Probably cost is something that we have already discussed, and we can consider also if we have this kind of images, if we need also pre-CT, something that we have discussed. And of course, we always ask for data. I don't know if it's worth enough to have a randomized trial mini micro TEE probe for ICE 3D, 4D probes. We have also seen a conformal case, and it was nicely demonstrated which are the possibilities of this new device, and also Jens Erik showed us a Philip case with this new ICE probe, and then also we have the experience with the Mayo Clinic, and also we have some attendees here that they have experience with this. To be honest, I mean, the quality of images you can see here are amazing, and maybe it's something that we can consider in the near future, as we have just discussed. Finally, Nina has shown us that it's quite easy, or this is feasible, to match ELAAC criteria, TE with CT. Do we need it? We have already said that. I totally agree that we need to do this, because there are many centers that are still using TE, so it makes totally sense to match our criteria with TE and CT. And what I'm not sure if we need an extra validation. I mean, that is something that is open for discussion. Do we need to validate this ELAAC criteria just based on CT, or will we translate the result with CT into TE? So finally, consensus and future directions. So I think that probably we can agree, or hopefully we will all agree in these 4 statements. So intra-procedural imaging is mandatory. I'm talking about echo. 3D and 4D imaging probably is preferred. We prefer that just 2D image. New mini micro ICE 3D catheters, as you can see, Sergio, I have included all of them in the same package. I mean, I think there's no competition between ICE catheter or micro or mini, can change our workflow. And I think it's clear that the ELAAC criteria can be used with TE. So which are the future directions? I think, and also we have discussed this, there's a problem for the expansion of this technology and its cost. It's clear that cost is a problem, of course reimbursement is a problem, and also I think here most of us, or all of us, are really experienced operators, really experienced echocardiographers, but I'm sure that we need training. I mean, there's a lot of centers that need training, they need experience, so I think also the companies has a big role on this, because I mean, if you don't have enough training, you are not enough experience, but you can have problems with this. Also, I think that we have already heard that it's not good enough to have 3D images from the right atrium with the ICE catheter. That make a big change, because if you are able to do that, you can screen the patient on the table again. I mean, if you need to cross, you need to do the transectal paralysis, not just a good moment to do the screen. I mean, you need to have a CT up front. And of course, this is something that is one of the aims of this club. We always need to think if we need more data, we are the trial, we are the study that we can propose. So it's something that, again, is open for discussion. And my last slide is not mine, it's Sergio, because Sergio has one proposal. So Sergio, you want to go over this proposal?
Yes, I think that the ELAAC club need of, can you go back to the,
can you go back?
Of a team of experts of imaging. In these 2 days we discussed how is important for pre-procedural planning, for the intra-procedural planning, and I think that Nina could lead this team. It's important to create a know-how, specific know-how for the new technology, for new imaging dedicated to the LAAC closure procedure, for the pre-procedural evaluation, for the inter-procedural evaluation, and we have to stay on the edge, and because we are the most expert in LAAC closure procedure, and we have to be the most expert also for the imaging for the LAAC closure procedure.
So,
I mean, from the discussion,
Nina.
from the discussion today, we learned how difficult it is.
You can only answer yes. I do it. Yes. Okay, Ignacio.
Yeah. So just one question for you. Do you think that we need to validate the ELAAC criteria also with TEE, so an independent core of patients, maybe based on the ELAAC registry, or just with the data that we are going to get with the CT analysis is enough?
Yeah, Ignacio, you can let them vote. Who is in favor of, we have to validate it for TE? There's consensus. Easy.
Good. And another question I did during my presentation, do you think that it's worth enough to make direct comparison between micro, mini TEE probe, or ICE catheter, or?
What is your opinion, Lara? Because I think the micro is not fair to compare, because the micro has no 3D capabilities at the moment. But is it worth to compare the mini TE and the 3D ICE?
No, I'm trying to say that compare ICE 3D catheter versus mini 3D catheter.
Well, I think if you are using 3D, it's this. For me, the important thing is to use 3D, but I think that choose what you have. So for me, I think it will be more or less equivalent if you get a proper 3D imaging of the only thing is the complications related with the access.
Yeah, that's it.
Is the thing.
Yeah, more hemorrhages in the esophagus with the TE probe and more groin bleedings with the ICE catheter.
I think that it depends on each center availability. It's like CT. So for us, I mean, so it's really like the cost, it matters. Then we have like a good echocardiographer. So I mean, probably like TE, mini TE works very well. Maybe in another center, like it's the opposite, no? I mean, like cost maybe doesn't matter, and they don't have like a good echocardiographer. So it's probably ruled by other factors that you cannot like do a side comparison, because I mean it's not applicable just to countries or other. So I think that it depends on
I think this is very reasonable. And Jens Erik, I mean, if you contribute to REDCap, I mean, we'll collect the data from ICE cases, we collect data from TE cases, and we we might come to some solutions or insights. So we don't, is there consensus we don't need a study for that? Who thinks we need a study to compare mini TE and ICE? Okay, there's consensus.
Yeah, no, Xavi.
I think that the question would be, can we compare the 3D possibilities of both mini TE or ICE compared to regular TE or CT? I mean, can we avoid the pre-plan with those 3D tools?
Yeah, I mean, Laura actually answered it, and I think yes. I mean, if the imaging quality, the 3D imaging quality is good enough, you have a 3D data set, you can do everything with it.
Do we need validation for that, or we are just happy?
If you are already doing pre-planning with a 3D TOE, it's the same that if you do it 1 week before or you do it on the table. So, I don't know, it's the same.
Probably for eyes we need that.
Yeah.
That's my opinion.
The only thing with the eyes for me is that the problem that you already open the eyes, that it's very highly cost, and you do the access before you see anything. The nice thing with the Mini 3D is that you, at the end, you can make the same that you are doing in the Echo Lab, that it's put a little bit of sedation and just look, and if there is a thrombus or a horrible appendage, you stop there. But with the eyes, you already need to open the eyes, to insert the eyes, and look at that. So,
Laura, I think we can prepare a proposal, a synthetic proposal to share with all the colleagues and to finalize this project.
Well, I think that we don't need to test the Mini 3D for planning. And I don't think if it's something that could be expandable to try to validate the 3D eyes in most of the centers because the cost. Because if you open the 3D eyes and then don't use it because it's thrombus or something, I think it's too risky at this point. Maybe if you can reuse the eyes or the cost is less, maybe you can do it. But now, from the point of view of cost, for me, it doesn't make so much sense.